Hello, everyone, and welcome to this special episode in which we will be discussing how to ace intern year. We will be having a special discussion with the surgical resident who will share his experience with acing surgical residency. So, we will start our discussion by talking about the rounding and the early day responsibilities. So, when we wake up as a surgical resident, what are you supposed to do? The rounding process, preparing notes, checking the charts. Can you tell us a little bit about what do you think new interns need to do to ace that first part of the day?
Sure. Different places have different times for when handoff is due. At my institution, it's usually 5 a.m. The incoming PGY ones get in around 4:45 or 4:50, sometime close to that, so they're able to get handoff from their peers on what overnight events transpired with the patients, and then they go about the process of making a patient list that comprises all the patients on the service, including both primaries as well as consults, and then they chart check these patients. Predominantly, what you want to look for are vital signs. You want to look at whether specifically a heart rate and blood pressure for most of our patients, unless they've had fevers and they've had temperatures. So with regard to heart rate and blood pressures, we usually like a range. The range that the patients often have can be pretty wide. Like some patients may have one random blood pressure reading that's 90 over 50, but then the subsequent one on recheck is like hundreds over 60s, 110s over 70s. So you want to know where they most commonly lied all across the last 24 hours. For example, when a good PGY1 presents, they say, oh, the patient was hemodynamically normal across the majority of the night, and their heart rate ranged between 60s to 80s, and their blood pressure mostly ranged from 120s to 130s over 80s. This may indicate that there was like a one-off blood pressure that was not okay, but for the most part, they've been within a normal hemodynamically normal range. So that's what you want to look at when you're looking at vitals. The next thing you want to check is labs. Usually, when you're chart checking at like 5 in the morning or 5:30 in the morning, the labs aren't up to date. So you just want to have your fishbone diagram drawn out to be able to fill out when the labs do update. Our EMR is accessible over phone. So during runs, they intermittently check their phones and update labs so that they have that available as we come down on the patient. The other thing you want to look at least on general surgery runs, is the flow sheets to check what the ins and outs are. Specifically, we're more concerned about the outputs, any tubes or drains, NG tubes, drains that exist. You want to know the exact output of what's coming out. Other than this, one of the questions that a PGY1 should always be asking themselves as they're chart checking a patient is, what is still keeping this patient in the hospital? What are the discharge milestones that need to be met? So then you kind of assess through the patient notes from the previous day to see if physical therapy has seen the patient, occupational therapy has seen the patient, if any consulting services need to be involved, have they seen the patient and have they dropped in recommendations? So you want to have all that ironed out so that when you present the patient on rounds, you have all these things listed saying, this is the final disposition, this is what the consulting services have said, they are okay with the patient going home, and ultimately you want to present your plan. So this is pretty much how you go about chart checking in order to have a fast and efficient round.
And if we say that surgery starts at 7, when do you recommend interns to start their day? When they should wake up? When they should start checking the chart? Do they usually pre-round before the actual round? How does it work?
So also very institution specific. For example, at my institution, surgery usually starts at 7:30 is the first case, and it really depends upon when the senior resident on service wants to come by to round, and that usually is around 6 to 6:30, depending upon the number of patients that they need to see in the morning. And as I mentioned, the PGY ones have their handoff times at 5 a.m. So regardless, they're coming in at very close to 5 a.m., around 4:50 to 4:55 potentially. With regard to pre-rounds, it really depends because there are services where you only have like 4 or 5 patients, and when you only have 4 or 5 patients, I think it's a reasonable expectation that the junior most resident on service sees them and has already seen them and has more elaborate plans ready at the time of rounds. But of course, if you're on a very busy service and there are like 15 patients, by the time you get through chart checking these 15 patients, it's already 6 o'clock and it's close to rounds. And you want to make sure that you have the list printed ready to go so that when your senior steps in, you hand them the list and you just walk out. You don't want to delay any portion of the day at that point, because a lot of times they're running just in time, if not mildly late. And if you delay any further because the list is not printed out or you're still checking something, then it ends up delaying them getting to their case on time and delays the progression of events for everyone. So I'd say it really depends upon the institution when you want to make that work.
I totally agree, and especially in the first few days for those who are gonna just start their residency in a few weeks. Be much earlier than you expect, because you don't know what's gonna happen. Sometimes the printer doesn't print well, and you have to go somewhere else. Somewhere you're lost in the hospital in the first few days, and you don't know where the rooms are, and there is something you can't know where it is in the charts, and you're asking people. So these unexpected delays account for that, so people don't think you're not doing your job on time.
Absolutely. I mean, those are like pretty routine occurrences, and it's you know, even when you're seasoned and you're halfway through your PGR 1 year, you still note that like some days the printer is out of paper and you have to go around to get paper. So always a good 5 minutes ahead is best to plan for, so that you act with the consideration for all these limitations that might surface at the last minute.
So when the senior on that rotation comes and you start rounding, how do surgical rounds look like? Because we know internal medicine rounds are totally different. Do the attendings usually round with you? How long do you spend per each patient? The flow, of surgical rounds. Can you tell us a little bit about that?
Yeah, so whether attendings round or not, again, is very institution specific, but most of the places, the way it works is the chief resident on the service rounds with the team early in the morning, and then they just run plans by the attendings when they see them. Attendings may round sometimes in the afternoon between cases, or they might see patients independently and let you know the updates and plans. But typically, the senior comes in around 6:15 in the morning and rounds start. It's a very quick rounding on the patients. The presentations are typically in the SOAP format: subjective, objective, assessment, and plan. So when you talk about subjective, you just want to, it goes famously by the 5 Ps: the pain, P, poop, pedestrianating, and PO intake. So you just want to know how the patient's pain has been overnight. You want to know whether they've been voiding. And when you talk about voiding, you want to talk about whether they have a Foley in place and what the plans for that are. Whether they've been passing gas or having bowel movements, and this is typical for most abdominal surgeries. Whether the patient has got up and walked, and that's a good time to mention about whether they've worked with physical therapy, and then finally what their PO intake status is. And at that point, you definitely want to mention what kind of diet they're on, whether there's any room for advancing their diet. And then you go to objective. In objective, it's just predominantly vitals, just mentioned in the way that I said in terms of the heart rate and blood pressures. And then you also want to talk about the focused physical exam. It's just an abdominal exam for most of the abdominal surgeries, or if it's a patient who's undergone some kind of chest surgery or some kind of neck surgery extra, then you talk about that relevant body part. It's not a complete physical exam. It's only a very focused physical exam to that aspect. And then you talk about the ins and outs as well as the labs if available. And at this point, you kind of put in any imaging that the patient might have obtained overnight, like somebody got a chest x-ray or somebody got a KUB, talk about those findings. And then finally, you present your assessment and plan. And the assessment typically goes, Mr. Jones is a 44-year-old male who's post-op day 3 from a laparoscopic sigmoid colectomy, overall doing well. And then you present your plans of care. Overall, the presentation for each patient usually is about a minute to a minute and a half. And the amount of time spent in the patient's room, of course, varies depending on multiple factors. But just as an example, for most of the times, we're getting through about anywhere between 8 to 10 patients in about an hour. So about 6-7 minutes per patient in the morning.
And I would say, even for plastic surgery, the process is very similar. Definitely, the presentation and what you discuss will be very surgery specific. So if you're talking about the flap, we're going to focus mainly on the way the flap looks, if there is Doppler signals, if we have an implantable Doppler. But if you have fracture reduction for like a mandibular fracture, you're checking mainly the incision, you're checking hematoma. So you'll get familiar with what you need to look for each surgery, and what kind of are the alarming signs for specific type of procedures. But the same, I would say, for most surgical specialties, you need to look at the patient overall, their vital signs, PO intake, their ambulation, if they have Foley, if they have tubes, if they have JP drains. It's very important, I would say, for all specialties to check the output, the color of the output, and you'll get
100%.
what is alarming, what is not. Um, Give us an example. Let's say you have a patient who had an appendectomy yesterday, everything going well, they had normal labs. How would you present that patient from A to Z to your senior?
So this is very senior specific. First off, appendectomy is probably not the best example to consider here because most of the patients who have an appendectomy overnight, pretty much even if they have it at 10 or 11 at night, we just send them home straight out of PACU. And if it's as straightforward as that, and the PGY1 is reasonably trustworthy or has, established themselves, you can just say, oh, this is our post-op day 1 appy, going totally fine, should be good to go, vitals have been normal. We'll schedule follow-up in 2 weeks, has been tolerating diet without issues and pains control. That's it. You want to be as brief as possible, and that's one of the main things about surgery rounds. You don't need to, even a lot of our colectomy patients, sometimes we just fly by this way just because time is short in the mornings and you want to get to your 7:30 case on time. So you present the most pertinent data. The way I mentioned earlier with regard to the SOAP format is like a classic presentation if you want to go for a full formal presentation. And I think that's important early on in your PGI 1 year as you're building a rapport with the team and trying to get people to trust you and kind of get to know that you know what you're talking about. But once they are familiar with your performance and they're like, oh, when this person presents, I'm comfortable knowing that they've checked all the stuff, then at that point your presentations go really, really short. And that's pretty much how I would expect a PGY1 reasonably early on to present a post-op day 1 appendectomy patient who has nothing else going on.
I see. If you have to pick something that actually someone stays for, and you have a surgery intern on their first week, you want to have them do the full presentation. Can you give us an example so people just have an idea?
Sure. So if you have, for example, a post-op day 1, let's take, for example, a sigmoid colectomy. Post-op day 1 sigmoid colectomy, you'd, present saying, oh, patient's been doing well overnight. Pains controlled, has been on clear liquids per our ERAS protocols, has been getting up and walking, has the Foley still in place left over from surgery, and then has been passing gas, no bowel movements yet. And then you go on to objective, you say, completely hemodynamically normal overnight. Heart rate's been somewhere in the 80s. Blood pressure has been completely normal, 110 to 120s over 70s. Abdomen exam is soft and appropriately tender. Incisions look clean, dry, intact. Labs are pending this morning. Urine output through the Foley was charted as about 1.5 liters. There are no other drains or tubes in place. So for assessment and plan, this is our 45-year-old male who's post-op day 1 status post-laparoscopic sigmoid colectomy. So plan for him today is going to be we advanced diet to a GI soft diet or a regular diet. He's already on his appropriate home medications. Incentive spirometry for his pulmonary function optimization post-surgery, replace electrolytes depending upon the labs, put the patient on a bowel regimen, insulin sliding scale if the patient is diabetic and needs to be on insulin, and then you always want to end up by saying what you're going to do for DVT prophylaxis for these patients, as well as what their disposition is going to be. So you say DVT prophylaxis, we can start the patient on enoxaparin 40 milligrams daily, which is our typical DVT prophylaxis in a patient who has normal creatinine or creatinine clearance. And then you say, going to remain on the floor. That's it.
Okay, that's cool. After rounds, what happens afterwards?
Afterwards, pretty much people split depending on their responsibilities. If there are multiple rooms running and depending upon the residents on service, 1 or 2 of them go to 1 or 2 different ORs, and the PGY1 tends to go to one of the ORs and often them sits in the OR and then starts doing both their orders as well as notes. And senior residents also start working on notes and orders on the side as the patient is being brought in and intubated extra. And the seniors will, at that point, talk to faculty and try to get plans ironed out to make sure everybody's okay with the plans.
I've heard in my first few months of residency that, put your orders first and then write your notes. Is that something you agree with, or how do you recommend efficiency in that process?
Yeah, the way to remember it is always consults, orders, notes. CON is how I remember it. And with regard to consults, usually orders versus consults really depends upon whether you're consulting a surgical service or a medicine service. If you're consulting a surgical service, like, you're on trauma and you're consulting orthopedics, then you want to consult them at, if it's 5 in the morning, they get consulted at 5 in the morning. It's not you don't wait. But for medicine services, they oftentimes switch only at around 8 a.m. So then you want to wait till about 8 a.m. before you consult. Otherwise, it's going to be you're talking to an overnight person, and then they're going to have to relay that information, and you don't want to have things lost in communication. So then you want to do your orders first, and then consult your medical services, and then finally notes are more of a last thing to do.
And what do you recommend to be efficient when writing notes?
This is like something also that varies both institution to institution as well as senior resident to senior resident. Uh, Notes are, especially for post-operative patients, are just soap notes. I think we just go off of pretty much exactly how you present. With regard to objective, you definitely want to put in like all the systems in there as opposed to just the focus system. But most of those are oftentimes not very relevant. And then in your assessment plan, usually I like the assessments to be only about 3 to 4 lines at max, because and that's also something that really varies from senior to senior. I've seen a lot of people who have assessments for patients that range in, that range kind of, like about a paragraph or so. They're practically like an HPI in and of itself, which in my opinion, assessments should be a 3 to 4 line summary, unless it's an extremely complex patient, that basically tells you exactly what's happening to the patient in those 3 to 4 lines. Um, and then your plans basically follow the exact same order. One of the ways to think about plans is you go down system wise from head to toe. So you think about neuro, so you think about the pain meds, then you think about cardiovascular, which is, talk about any home meds, palm, so you look at incentive spirometry or any, home albuterol or something like that. Then FENGI, which is electrolytes, nutrition, as well as GI drugs like bowel regimen and so forth. Then you talk about endocrine, DVT prophylaxis, as well as disposition. So these are the elements that you need to put in your note. If it's a consult note, a history that you're writing from scratch, then it needs to have all the elements of a complete HCP. But one of the things that people often don't realize is that notes that are written in the post-operative period for a period of 90 days for most surgeries are not billable. They're considered the surgery global period. So realistically, the notes that you're writing are for one, your own reference, as well as the team's reference and other teams' reference when they consult on this patient. They're not for they don't contribute anything to billing. So writing extremely detailed progress notes is not very useful, because it's pretty much mostly for self-reference.
Now let's talk about consults. Generally, there is a person to see consults during the day. What do you recommend from an efficiency standpoint, from a completeness standpoint, for someone who's covering consult service and not currently in the OR, from seeing the patient, things that they don't need, they should not miss, and writing these notes, discussing with the attendings?
So for us, we don't really have a specific consult only person. It's just it's typically the junior most resident on the service who gets the consults, and then if it depends, if they're scrubbed in the OR and somebody else is free, one of us goes and sees the consult and takes care of the note. But usually it's the PGY1 or the junior most resident on service who is seeing and evaluating this consult. One of the things when you get a consult as a surgery resident is you want to always ask what the consult diagnosis is. That is usually my first question that I ask the team when they're calling. And the reason is because the way they end up starting oftentimes is, oh, I have a 30-year-old male who has some nausea, who has some vomiting, who's been having some fever. And by the time they get to the point where they're telling you why they're consulting you, it's already been 3 minutes. So you want to know exactly. The first question should always be, what is the consult diagnosis for which you're consulting this specific surgical service? And then they tell you the diagnosis. And after that way you have your mind primed on what exactly you need to hear. And then you kind of try to take, the pieces of information that seem relevant. And then most of the times they give you about a 50 to 60% picture of what exactly is going on. And then there's some parts that you need to figure out. So then one of the important things that you want to always see, especially in case of surgical patients who you're getting consulted on, is, has this patient ever been seen before? You want to chart check and see if there are any notes in the system, any previous discharge summaries from either a surgical consult team or from a medicine team that gives you an outline of what this patient's been through. So through that, you get most of your past medical history. And you also want to try to research some of the past surgical history if it's available in the system. That way, you kind of just hear what the ER or the medical team that's consulting you or the other surgical team is telling you about what the patient is presenting with. And then you want to quickly run through their labs, check how the labs look, take those down, and then run through the CT scan or the images that they have up in the system. And then you go see the patient, and then you know exactly what you're looking for. You ask them the remaining questions just to fill in the blanks, and after that you come up with a plan, and then you present it to your senior with the plan. That way you're kind of complete. You've already checked, you've checked out the history, you've filled out the blanks, you've done your physical exam, you know what the labs look like, you know what the imaging looks like, and then you come up with a plan for the specific consult diagnosis.
Yeah, I totally agree with that. And I like the fact that you mentioned to check everything before you go and see the patient. That's something I like to do, because if you just go see the patient and you don't know what the problem is, you haven't looked at the scans, it's most of the time you're wasting your time. So you need to kind of
True.
have all the information you need to know, because sometimes the patient don't know what medications they're on, they don't know, what that diagnosis that they got admitted for last week, which might help solve, target you towards what you need to ask. If you know that this patient had maybe acute diverticulitis a week ago and now they're presenting with something similar, it's better than just going and figuring things out in the patient room. And sometimes the patient will tell you, "Oh, I just got a CT scan last week. Didn't you look at that?" So just
Yeah.
that will be prepared for all these questions.
100%. And also, one of the major things you want to see on the patient's chart is blood thinners, whether there are any blood thinners, because that's always important when you're looking at evaluating this patient as a surgery candidate and potentially undergoing surgery because they're consulting a surgical service.
And one important thing you mentioned is the imaging, especially for specialties like general surgery, where imaging plays a huge factor in deciding what to do. You need to learn how to actually read the imaging. Don't just look at the read of the radiologist. And this is something
So,
general surgeons actually stress on a lot, is that you actually have to look at the images yourself and figure out what's happening, and then you can look at the read for confirming. But you'll see a lot of general surgeons will go through the scans with you. They want to make sure that you can actually read the x-ray, read the CT scan. So that's very important to do, as I would say in most surgical specialties. Another thing, have a plan. A lot of people are like, oh,
100%.
what should I do? No, that's not the point of you seeing the consult. You need to see the consult. Even when you're presenting to your senior, not necessarily you're attending, you need to tell them, and I think we should do this, or my plan is 1, 2, 3. And even if it's wrong, it's fine. They can correct you. You can learn from your mistakes, but don't just ask, oh, what do I need to do now?
Yep, totally agree.
So let's shift gears and talk about a few other things, which is studying. Surgical training, you said you usually start at 5 a.m., which means you probably have to wake up at 4 and you're probably sleeping, finishing late. When do you have time to study? And do you actually need to study? Many people think like, oh, I finished med school, I'm done. Can you tell us a little bit about that? What expectations do surgical residents have regarding studying? Do they have exams?
Sure. So we have the app site every year, which is our in training exam. Studying is ideally something you want to do every day. The way my program director mentions it is that you try to study 30 minutes a day for 6 days a week. And that is a good study habit to build. Again, I think, different people are different. A lot of people, I think, just read close to the exams, which is not the best way to do it, because there's more of a continuous learning process as opposed to a periodic spurt. Because our app site is in January, if you look at the patterns of usage of the question bank and things like that, everything has like a little spike towards November, December, when people are starting to realize the exam is close. I think it's important that everybody just studies for their respective rotation and for the cases that they're participating in, and that way you accumulate some degree of knowledge every passing day. Like if you have a case the next day, you read up about the pathology, you read up about what exactly is done in the case, and I think that allows you to draw a lot more benefit from it and be more involved during the surgery itself. And by doing that over a period of 5 years, you've kind of gone across a majority of the conditions, and you don't really have a whole lot of gaps left to fill. And then you just update yourself with recent developments and journal findings and changes in practice.
That's very important, and especially the fact that you need to prepare for your cases, because most of the time, you've been seeing concepts about some topic, but you have like a different case tomorrow, and you will realize that attendees will not give you opportunities if you don't know what the case is, what the presentation, diagnosis, even if you know the surgical technique. So you need to be prepared well to get that opportunities. Do you see that in your training, Ashish? Have you seen, like, if you
Yeah.
don't know it? but the case is people won't give you as much opportunity in the OR.
100%. And I think that's very fair, because if you don't know what you're, if you don't know the patient in and out, and you don't exactly know what you're doing or why you're doing something, then in reality you shouldn't be doing it, because I think it's something that you at least owe to the patient, that you're operating on them, that you know exactly what you're doing and exactly why you're doing something.
One thing that a lot of surgical residents require is to have some type of research experience in type of projects or presentations. What do you recommend for people who are supposed to do some type of research or interested in doing research with the heavy load of surgical residency and the heavy load of like studying and so many things you have to do?
It's hard. A lot of people take 2 years out to do dedicated research. There are opportunities that are often there where you can participate in different ongoing projects with other residents and so forth, and you just have to source them out. But if you really want to push forward and do something as first author, you're going to have to spend a decent amount of time and potentially weekends doing it. So I leave that up to individuals' discretion, because it's how you want to manage your time.
Yeah, some people, as you said, take, especially in general surgery, I see a lot of programs are pushing for the 1 or 2 years of dedicated research. But I've seen so many people being productive, and you're one of them, without taking a research year, that you dedicate nights and weekends and sometimes vacations and holidays to do some research. And there are always opportunities in most programs. If you're interested in learning how to do research, we have multiple courses that teaches you that, from how to do clinical research, statistics, systematic reviews. So I'll leave the links for all this in the description below. But at the end of the day, it's your dedication, how much time you're gonna spend on weekends doing research that will result in how many papers you have.
Yeah, I agree. It's a lot of self effort if you want to do it in parallel with residency.
I totally agree with that. And let's touch the final thing that we'll talk about is surgical skills. We've been talking about consults and seeing patients and notes and rounding. And at the end of the day, surgery is, you're doing surgery, you have techniques. How do you develop that as a surgical resident? You don't get crazy amount of opportunities as an intern. So what do you need to do to improve your surgical skills?
I think it's passage of time. You also have our program has a simulation lab, and we have a rotation in our simulation lab 1 month of the PGY 1 year, and where we're expected to go and practice and master a lot of the knot tying, suturing, and so forth, including laparoscopic skills. So, and the PGY ones are involved as much as possible during cases. So even if they're there only for a short portion, we get them to do level appropriate portions, and therefore it's a process of constant refinement. You realize that you don't do something as well as you thought you would, and then you try to work on it in the skills lab, and then you get better, and then you do it the next time, you do it a little bit better, and then as you go through 5 years and come out, you feel comfortable and confident doing those skill sets.
Ashish, it was very nice talking to you. Thank you so much for spending time with us.
Well, thank you for having me, and I wish everyone the best.